So let's talk about obstetric violence.
Yes.
What do you think about that one? That's a big one.
It is a big one. And it's unfortunate. It happens all the time. I've seen it as a doula before. I know you've probably seen it before as a provider. And I guess kind of the big thing is knowing that it happens and knowing how to prepare to advocate for yourself if you experience that.
I think it's important for people to know that we're talking about not just physical.
Right.
It's verbal,
Coercion.
sexual, coercion, and it happens way too many times. And I feel like people are not comfortable addressing their providers.
Right.
That's one of the bigger problems.
I think especially when you're in labor, you're in a very vulnerable place. You're often in pain. Many people aren't educated about the process. They don't know what to expect. They don't know what's normal, what's not normal. And the doctor holds authority to them. And they view that as a person that has authority. And when they come in and say, we're doing this because of this, people are too afraid, too vulnerable, not in a place to question it, and don't understand that they have the right.
And it's not just the doctors, right?
Right,
It's
it's
midwives, nurses, anyone who will come in contact.
Right.
And I think about, first of all, let's just talk about obstetric care. In most hospitals like Winchester and others, there's a form you sign that you consent for obstetrical care, which includes vaginal deliveries in case of medical indication, cesarean section. So usually that's reviewed, signed, and it's in the chart.
Right.
But if I really think about in what scenario would I ever do anything without patient's consent?
Right.
And people could say, well, emergency. Well, the truth be told, there aren't very many true emergencies.
Right.
It's not that common. So we're talking about cases, the common ones are, of course, vaginal exams when the patient doesn't want one.
Right.
Right? That's one.
That would be one, yeah.
Because of previous history, sexual violence, rape, whatever the history is, there may be a reason for that.
Right.
And then forced C-section.
I've seen one of the most obvious cases that I've seen was a patient came in and was in very early stages of labor, but was admitted because her test came back positive for preeclampsia. And the provider wanted to break her water and wanted to start Pitocin. And the provider came in, and I don't know what the conversation was earlier.
Tell us, which hospital was that?
I can't.
Okay.
I have to stay.
You want the referral, right?
Yes, exactly. No, that's it. No, this is more for the case of the sake of the patient.
Yeah.
But the provider came in and said, "Lay on the bed. I'm not asking your permission. I am breaking your water. I am not asking your permission. I am starting to Pitocin. And if you don't let me, you and your baby are going to die."
So I don't even know where to start with that comment.
Yeah.
Because that doctor obviously is practicing based on his or her insecurity. Because you're assuming by breaking the water, rupturing the membrane, by starting Pitocin, it's going to end in a vaginal delivery in timely manner that would suit the provider.
Right.
It just doesn't happen that way.
And I'm sure you can guess how that delivery ended in the OR. After the patient pushed for 3.5 hours, the OB came in and said, "I think we can have a baby vaginally if you want to, but you're not trying that hard. So I'm going to give you 20 more minutes, and you can decide now if you want to try harder or if I should just take you into the operating room."
Who are these doctors? I need to make a list of most unwanted doctors.
Yeah.
Because these doctors suck.
Yeah. And, after the first interaction with the doctor, when the doctor left the room, I said to the patient, let's call the patient care advocate, because that's not right.
I don't even know what to say about that statement by that doctor, because, this is why there has to be a way for maybe that doctor needs to go back to not school, but some kind of program, retraining,
Or maybe
learn how to talk
retire.
to doctors, or retire.
Yeah.
Because if he or she was allowing this patient to push for 3.5 hours, what's another 30 minutes? What's another hour?
Right. And the patient was so close. And I think if the doctor had come in and been like, we can do this, like, you got this, let's do it. Give me that last bit of energy rather than you're not trying hard and I don't think this is going to happen. So
I'm glad you mentioned this because we're talking about a patient who's very motivated with or without a doula,
with a doula, yeah.
right? In this case, with a doula.
Yeah. And
And
very
also-
well educated, took hypnobirthing, was prepared.
And then another factor is the nurse. That nurse has to be experienced, motivated, supportive. And in order for that to happen, it's the doctor, the midwife, whoever the provider is,
Right.
has to be right there. And I have had plenty of cases where I'm in the room pushing with patient
Right.
for 2-3 hours.
Right.
Because one, I always say we can do this because you're fine and baby's fine. And I know this baby can come from below.
Right.
And because any negative, I can't imagine I'm lying on my back and I've been pushing, any negative is going to take away all positive energy.
Well, especially after you've been doing this for 3.5 hours. I mean, that's a long time. And I'm sure by that point you're getting discouraged of why haven't I had my baby yet? I'm trying as hard as I can.
So that doctor's name should be on like a neon sign and put up wherever the hospital is and say, do not go to this doctor because you end up with a C-section.
Yeah.
The patient had a C-section.
Yep, had a C-section. I mean, and the baby was there. I mean, every time she pushed, you could see the head coming out.
So another scenario would be, if I don't do I need to do an episiotomy. I'm saying there's a well-known case out of Southern California where a patient, actually this doctor tried to do episiotomy 12 or 13 times.
Oh my gosh.
And the patient, and I think he said, if I don't do this, baby's gonna die.
Yeah.
So 12, 13 times trying to do an episiotomy, that I don't even know how that doctor got a license, but
Right.
that's another time where doctor would say, I need to do an episiotomy.
Yeah.
Instead of maybe talking about it,
Right.
pros and cons.
Right.
And I always say, the last time I did an episiotomy, I don't know, when was Reagan in the White House? It's been
the
a while.
80s.
In the 80s. Okay, it wasn't Reagan. It was another president.
Late
but
80s.
It's been a while. And because you don't really need to do it, even if vacuum delivery, it's not always required.
Right.
So there's always that time you can have that discussion with the
Yeah.
patient.
Yeah, I think the important thing is always making sure that the patient understands what the risks are. So rather than saying you will die and your baby will die, explain what the risks are. Explain what your reasoning behind is. Have a conversation. Ask them if they have questions. Not saying this is what we're doing and you don't have a choice, because you always have a choice. It's, your
I
body.
mean, how often do we hear these stories?
More than we should.
More than we should. And good number of us, obstetricians, are responsible for these bad behaviors.
And the one thing I'll say is, after this particular scenario, we were in recovery and the patient was, happy that her baby was there and the ordeal was over. And she said, I never really liked her at any of my prenatal appointments.
Then why did she keep
But
going?
she had a good reputation. So I thought she would be different when it came time to deliver. And I just have to say, if you have this gut feeling throughout your entire prenatal care, listen to it, because that doctor is not going to be, midwife, whoever, they're not going to be different when it comes time to deliver.
I think that clear communication from the get-go needs to be established. And what you just said really makes sense, because you have to be able to verbalize with your provider. And I can't really imagine any time that you cannot. You should always be given option A versus option B. We also talked about a case where a failed home birth patient ended up in a hospital in the area, and the physician, I think, said, how dare you try this at home?
Yeah.
Right? And she ended up with a C-section,
Right.
and the patient is still traumatized.
Yeah. I mean, birth trauma is a real thing. You know, so often you hear this saying of healthy mom, healthy baby, that's all that matters. And obviously, like, everyone wants to come out of this with a healthy baby and for them to be healthy, but getting from point A to point B matters. If there's a lot of, you know, traumatic things that happen, it's going to have a huge impact on your mental health, sometimes your physical health, and your relationship with your child, your postpartum experience.
It's a significant component which may affect postpartum recovery and depression.
And your desire to want to have more children and your health in the next pregnancy.
I'm familiar with a case where overall things could have gone better, but because of this particular labor and delivery outcome, the patient does not want to or afraid to get pregnant again.
Yeah.
So the damage is huge, and I don't believe we as providers are taking enough blame. And I would also hopefully tell your friend or your client that she didn't go back to the same one for the next one.
I don't think she's had a second one yet, but I did see her reaching out on some boards asking for a recommendation. So hopefully she will be moving on.
So I think, you know, only way for us to really make any difference is all these patients share their stories and let others know, because it's like, look, if it's bad Chinese restaurant, I'm not going to have any customers. If people say don't go to Chun's because food sucks, who's going to come?
Right.
But that doesn't happen with doctors, in which I don't really understand why.
And I think another thing that people need to know is if you are delivering at a hospital, there are patient care advocates that are there to work for you. So if you get yourself into a situation like this where, you know, whether it's in labor and delivery or any scenario where you're having this really negative interaction with a provider, with a nurse, whoever it may be, and you don't feel like you're able to advocate for yourself, that patient care advocate is there for you. You can call them. You can talk to them about what's going on.